platform with Dr. Dlakane, who is a physician. And I, for my own sins, I am not, I'm trained as a clinician, but I don't see patients. So she would add that component to the discussion. And some of you may know, but probably most of you don't, that I've been engaged with the discussions around COVID for the past year, different parts of it. I'm trained as a family physician, but I work mostly as a public health scientist. And I tend to try and see how the different pieces of the pandemic kind of fit together, how we can connect the dots. And the issue of long COVID, of course, really, it was there in the media for a while before it really caught our attention around June, July last year. But in South Africa, we were in the middle of our first wave, so we couldn't really be distracted from that. But it's something that we have neglected as a result to have a detailed conversation about. It looks like the conversation is generally starting, not based on just this symposium, but in other circles as well. So I'm hoping that we, in this way, will be opening that discussion, which is really, truly long overdue. I also want to just open by saying that my experience in the past year has been that we've been navigating a condition that we knew very little about, and there's constantly a lot of uncertainty. And I want to say that that's okay, because many times I think that I've come across people who are experts in their own fields and who felt quite uncomfortable not knowing. But it's okay. I mean, I've come to terms with the fact that we're not going to know everything, and we are constantly going to learn to try and fill those gaps, and we'll constantly revise our knowledge when new information emerge. And you will see as we talk a little bit about this that it's something that we have to just make it normal practice. And the other thing I want to highlight is that we have all been affected by COVID in one way or another, directly and indirectly. And we have to remember that. Someone was saying to me that, you know, you're busy worrying about everyone else. What about you? And I was like, but I haven't had COVID. And they said, well, are you saying that you have not been affected by COVID? And it took me a while to actually sit down, reflect, and actually realize that there was a lot of emotions that I was dealing with around this. And I'm saying these things to just introduce the complexity of this topic for everyone, to say that we are dealing with something that is very complex in COVID-19, but also when it comes to long COVID, it's even more complex, as you will see. But we tend to think of it in terms of how it affects other people, and not so much how it affects us, whether you've had actual clinical COVID or not. But so if we then open our minds to this, then we'll be able to engage a lot better with it. I understand that a lot of colleagues here come from an occupational health space and basically think of COVID in terms of the workplace. But I think first of all, let's think of it in terms of the fact that it affects people. And people are going to be individuals with certain personalities, interests, come from certain families, come from certain contexts before they come into the workplace, and have different ways of responding to different challenges. And it is in that context that I would like to locate this discussion that we are going to have. And we've tried to keep the presentation itself brief so that we can have a little bit of discussion at the end. We have revised our knowledge around COVID-19 so many times in the past year, many times. And what we are going to discuss today, we are also going to revise over the next few months, and let's be okay with that. So let me invite Dr. Siphokazi Dlakane to introduce the issue, and then towards the end, I will sort of talk a little bit about the evidence that we have so far and what it means and its implication. Thank you, Ntantla, and please, if anyone has any comments, you can put them in the chat box so that if there are questions or issues to pick up, we can try and pick them up as we go along. Dr. Siphokazi.
Good morning, everyone, and thank you for joining us this morning, and thank you for giving me the opportunity to be part of this discussion. And like Prof. Moshabela has already mentioned, there's a lot to learn. We are revising the information as we go along, as we learn new things. And I think in our setting, we really have been fortunate in the sense that we've had other parts of the countries of the world going through the surge before us or the waves before us, and we've had the opportunity to learn from them. So my talk will start with a presentation of a case of one of the nurses that I actually work with in one of the hospitals. Ntantla, can you put up the slides, please? Thank you, Ntantla. So I'm going to this morning present a patient known to me, also a colleague, a nurse colleague who is ICU qualified and also a clinical nurse specialist. So Mrs. KG is a 52-year-old female with no previous comorbidities. Her symptoms started on the 15th of June. She presented with a sore throat, headache, dizziness, and non-resolving fever and fatigue. On the 17th of June, her diagnosis of COVID was made with a positive PCR. Following this, she had multiple visits to our ED department where she was presenting with a multitude of symptoms, which progressed to chest pain, palpitations, fatigue, and chilblain toes. She was never actually admitted to the hospital, but only seen in our emergency department. On the 19th of August, she then suddenly developed a new symptom, which was severe abdominal pain with dysentery and a brief period of where she oxygen levels had dropped. This now required an admission to the hospital. She was admitted under the care of a surgeon, and a CT abdomen showed features suggestive of an active colitis. At this stage, a decision was made not to do a colonoscopy and to call her back at a later stage for a colonoscopy. She was called back to be admitted on the 4th of September. On this admission, she tested positive for COVID-19, and this was a PCR test. At this stage, we had a bit of a dilemma because given her duration of her symptoms and the initial diagnosis, was this reinfection? We actually sent hair specimens to our National Institute of Communicable Disease, where they analyze the specimens. However, because we don't keep specimens in our laboratories, we couldn't make the diagnosis whether she was a reinfection or not. But based on the probabilities and the clinical presentation, it was decided that she was not a reinfection. At this stage, she still also had ongoing symptoms of fatigue, myalgia, palpitations, and brain fog, back pain, and shortness of breath, and has spent a lot of time being on and off work. She could never work for more than a week at a time. Next slide, please, Bradley. Sorry, Ntantla. Okay, this brings me to the topic of today. How do we define COVID, a long COVID? At this stage, there is no agreed definition. However, certain groups have done some studies and have published guidelines to give us a guidance as to how we're going to make a diagnosis. So it is defined as a person who's experiencing symptoms for more than 28 days after either a laboratory or clinical diagnosis. And that is actually a very important point, because not everybody would have had an opportunity, especially in our setting, to have had a test that actually confirms the diagnosis. And the fact that one does not have an actual PCR test or any other laboratory confirmation does not exclude the diagnosis. The National Institute of Care and Excellence has actually also published guidelines, which then further breaks down this diagnosis into two categories. One being ongoing symptoms of COVID-19, which are symptoms that last between 4 to 12 weeks from the start of the acute symptoms. And then the post-COVID syndrome, which is symptomatic patients beyond the 12 weeks of their diagnosis. Next slide, please, Santa. So most of the patients, it's been estimated that between 10 and 30% of our patients will have ongoing symptoms beyond 28 days. And that for us is actually a staggering amount of patients that are going to suffer some kind of these symptoms. As of yesterday, our national statistics show that about 1.5 million people have been confirmed COVID-19 patients in South Africa. Like I said previously, there is many more patients that have not been confirmed. So if we had to take the conservative figure of 10%, you will realize that about 150 to 450,000 people are going to suffer from these symptoms. The studies that have been done in our country by Mendelsohn et al. From the NICD and Prof. Bloomberg have stratified the patient that have got the risk factors. So patients that presented with more than one symptoms at the acute onset of their disease, patients with an older age, which is defined as more than 50 years old, the female sex and obesity seemed to be risk factors. But like previously said, we're still learning about the disease. The pathogenesis of the disease are likely to be multifactorial. And the hypotheses for them range from anything from the deficiency of nicotine adenine dinucleotide, viral persistence, post-infectious inflammatory syndrome, and residual end organ damage. Next slide, please. This slide actually shows us a visual view of what the complication of the organ damage is, and Prof. Moshabela will actually take us through the studies that have been done. But the most common symptoms were fatigue, headache, sleep disorders, chest pain, a persistent cough, and myalgia. And most of our patients also had brain fog, which my patient also had. Next slide, please. So this next slide actually speaks to the above slide, where we have depicted what these symptoms will be. So patients can have anything ranging from pulmonary complications, which can be pulmonary fibrosis with persistent shortness of breath, some of them even requiring to be on oxygen, and also a pulmonary emboli, which is clots in the lung, and bronchiectasis, which is damage to the lungs. The cardiac manifestation can range for anything from a myocarditis, new onset heart failure, hypertension, the brain and nervous system. And this is a complication that has been mentioned most by our healthcare workers, where they have what we call brain fog, which ranges from anything from poor memory, forgetfulness, and poor fine motor coordination. One thing that we shouldn't also forget, this disease is a multi-system disease and also affects a whole lot of other organs, and mental health becomes quite important. Some of our patients have suffered from symptoms ranging from anxiety, depression, and post-traumatic stress disorder. What will be the impact of the disease in our population? Given that we have not at this stage defined the problem and the extent of the problem, but we are aware that we are going to have at least 10 to 30% of our patients suffering long-term impact. Given our low income state of our healthcare systems that are already stressed and overburdened, this is also going to add another burden that will need a multidisciplinary team to manage them. And we know that we are not that well resourced in terms of our health care worker in all the disciplines. On top of that, this is also going to add an economic burden. I mean, we know our high unemployment rates in our country. And if we now have patients in the age group that is supposed to be economically active, and now they're being affected by a disease that is going to keep them off work, meaning that there's actually less employed people to contribute to our tax and our economic growth as a country. The other challenge that we are going to have, as previously stated, is that it doesn't have to be a laboratory confirmed test that makes the diagnosis. And the majority of our people are unable to test. And we would know that, especially in our first wave, the facilities to actually do the tests were not that easily accessible to the majority of our population. So now imagine somebody who's had the disease, didn't know that they had the disease, couldn't test, would have no way of confirming that indeed this is what has affected them. And they may then lose out on their sick benefits. And it will be very difficult for them to actually prove occupational exposure, especially in the fields where patients are likely to be exposed to a high burden of the disease. Like in my instance, where people work in a healthcare sector where they're exposed on a day-to-day basis. Next slide, please, Ntantla. So as previously stated, this slide just depicts the percentage of symptoms that these patients will suffer. And in the majority, the fatigue is quite prevalent, shortness of breath, chest pain. And you can imagine somebody who needs to be at work for long hours, especially in our case, who's a nursing sister who's there for 12 hours, has to teach, has to manage patients in ICU, if these are the kind of symptoms that they are suffering on a day-to-day basis. Next slide, please. So this brings us to the importance of educating first our population, not only the general population, the healthcare workers. I actually went and did a survey, a snap survey of the ICU nurses that were affected by COVID-19 in the first wave. And the symptoms that were depicted in the previous slide are quite prevalent. And one of the concerns is that the healthcare workers had actually mentioned to multiple clinicians, either during their ED visits or even during the ward rounds, that they were actually suffering from this condition. And many of us either were not aware of the condition or in actual fact, were not sure how to address the situation. So they felt unheard, no help for them. However, there are resources out there that can be used to help these patients. The World Health Organization has actually put out an update that actually patients can access as well to do self-help exercises. But rehabilitation will actually have to include a multidisciplinary team involving clinicians, physiotherapists, occupational therapists, occupational health practitioners, and most importantly, also the mental health care services. How patients can help themselves at this stage, what we know is that fatigue and low energy levels may be helped by graded exercise programs. Respiratory or cardiac rehabilitation programs may be useful, particularly for patients who've had COVID-19 confirmed and severe disease at that. Breathlessness and cough may respond to breathing controlled exercises. Patients should be referred and assessed for symptoms of anxiety, depression, or post-traumatic stress disorder. They should be helped with stress reduction techniques, peer support, and referral to mental health care professionals. I'm also quite aware that on our social media platforms, there's a lot of peer support groups which have done a stellar job to make the voices of these patients heard. Patients with anosmia, which is a loss of smell, can also benefit from olfactory training. Of importance is that athletes and patients with physical demanding jobs with confirmed myocarditis at the acute phase may only resume exercise after a period of rest, which is usually about 6 weeks, and also should be referred to a cardiologist for assessment. Next slide, please. So the challenges that we're going to have, as Prof. Moshabela has alluded, that hasn't been much of reporting on the condition. In our setting, the research has started, especially with the national NICD, which is our National Institute for Communicable Disease. But we need to get this disease recognized. And I think we will also need to lobby our government to recognize this as a disease entity so that much funding can be lobbied for research, for us to establish the diagnostic criteria, to also establish a patient registrar, and also establish treatment guidelines for these patients. Follow-up, as discussed, will need to be done by a multidisciplinary team. Of course, in our setting, there will be challenges with staffing, training, and capacity to manage the patients that are going to have this condition. But it is very important that we do set up these post-COVID follow-up clinics. And I'm actually quite glad that in our midst, we have people who have already started and are running these clinics. And we've got a lot to learn from them as to how to start the clinics. So the gift of time that we've given, I think it's quite an opportunity for us to use that gift of time to learn from our peers who have already got the research going, who also have got the clinics going, who can give us much valued inputs. Next slide, please. I think at this stage, Prof will probably take over and discuss the studies that have been done and the research that has been done. Thanks, Ndla.
Thanks, Siphokazi. Ndla, I think you can project the slide. So even if it freezes, it's fine. It's not a problem. I want to thank Siphokazi for framing the discussion, but also start indicating the fact that when we look at long COVID, in the context of South Africa and generally in Africa, we don't yet know enough about it. And so we have found ourselves in a situation whereby we are resorting to literature that comes from elsewhere. One of the recent papers that was published in South Africa, it's a collaboration of colleagues from Cape Town, from Joburg at the NICD, who basically started to frame the discussion in the context of South Africa. And what is clear from that framing that they are putting forward is that in South Africa, we've been focusing a lot on patients who are coming from ICU admission. And those are the ones that have been receiving follow-up attendance. We don't yet engage in follow-up for patients who have been in outpatients, but there is quite a bit of literature that suggests that it's important to also look at patients who are just outpatients. And also, as Siphokazi said, is that we must not only focus on patients who were diagnosed with COVID-19. Some patients were never really diagnosed and they never really knew. And they will form part of this population that we have to pay attention to. Now, I need my slide, Dlakane. But what has been interesting for me is that the issue of long COVID was actually brought up by patients. And, you know, when the disease starts to affect people who are also healthcare professionals, they take interest in paying attention to the symptoms and framing the challenges. And they were able, through social media, to basically start to tell these stories. And, you know, we've heard of I think it's Elise Pereno from Italy, who basically started this hashtag long COVID, which was basically meant to represent hashtag, yeah, you can leave it like that, it's fine, thanks. Who was basically meant, which was supposedly meant to be long-term COVID-19, and it was short for long COVID. And there's this paper that Perego herself, together with Khalad, have put together in Social Science and Medicine to tell the story of how people who were affected by COVID came together, mostly, in Italy, China, and also in the US, who basically started to lobby for attention to this problem. Now, this is a problem when you find yourself in a situation whereby it's a problem when you find yourself in a situation whereby you are a patient and you're saying, I have a problem, and that problem is not being acknowledged. This is really the problem. And I think as healthcare workers, it's really important that we need to acknowledge the problem exists. We may not know about it. We may not have enough literature about it. We may not be able to investigate it, to treat it, to confirm it, but we tend to generally undermine subjective experiences of illness. And we've got to deal with that problem, because in this case, we tell people you have recovered after they test negative. But actually, what does recovery mean from a personal experience of illness point of view? That's the issue. And so this is how these communities came together to basically mobilize. And it took a while before the leadership in the world could acknowledge this problem. It was the US, the WHO, and others. It took them a while until they eventually acknowledged that there is some sort of post-acute viral syndrome that happens. Now, for us here in South Africa, the first study that really struck a chord was the study from Italy that basically followed up a whole lot of patients who were seen in the hospital in Italy, in Rome, and then were discharged, and they came back for follow-up. And when they came back, there were like these persistent symptoms in patients, and it was around June last year when the paper came out, and it made big international news. And at the time, of course, we didn't really understand the condition, but it was staggering, the number of, the percentage of patients with ongoing symptoms. And at the time, it was around 87.4%. And presumably, these are patients who were very sick. Soon after, China also brought out a paper that showed that, there were all these persistent symptoms, and it was about 63%. And then the CDC also released a paper around July that basically spoke about this delayed return to usual health. And it was coined in this concept of, in the US, they refer to it mostly as long haulers. It was coined in that context. And they actually looked at outpatients, which was, for us, again, different from what we had seen before. And the results were staggering, that it was around 35% of people with persistent symptoms. And more data began to come out. And in the UK, they were able to basically do a qualitative study, a large qualitative study, to try and understand the subjective experiences of these patients. And some of the striking things that were found in that study was that when patients complained, they were frustrated with the fact that they were not believed. They did not believe, the health workers were not believing that they were suffering from these symptoms. But they highlight the importance of support, providing support for these patients. Now, generally in clinical diagnosis, if you have had COVID, you come back and then you still have symptoms, but your test is negative. Generally, we would say that, well, you don't have COVID. But actually, what does that mean? How do we then deal with the stages of illness that people experience. You know, there are people who would have asymptomatic illness, there are people who will have symptomatic illness, and then there are people who would have post-acute symptoms. And then you have people who have long-term sequelae as well. How do we then engage with that? And when you now take that out of the clinical environment and you put it into the home environment of that person, the stories you hear of how people struggle with tiredness and fatigue, if you put that in the working environment, I mean, some of the stories is the people who say that they are no longer able to cope at work. How do we validate their experiences so that we don't necessarily dismiss those experiences? And how do we then put in place the infrastructure to support them, the policy environment to support them? How do we actually assist them further to make sure that they receive the care that they need, including all the rehabilitation that Dr. Dlakane has spoken about? These are the things that if we do not necessarily acknowledge the problem and validate these experiences, that we are going to fail to intervene, because we'll get to a point where we'll say, well, we can't help you. And from a clinical perspective, it's going to be that, you know, you need step-down care, or you need primary care support, but we are no longer, we can easily fail to validate those experiences. Now, there is also this paper by Greenhawk Trish, who basically presents some sort of a framework for management of post-acute COVID-19. And she uses the same sort of a percentage that Dr. Dlakane uses, of around 10%, and it is a conservative figure. But in the UK, Sudrendam basically did a study where they were looking at logging of symptoms, and in their study they find that you know, these symptoms would decrease in time. So in the first month you'll have about 13%. After 2 months it's 4.5. After 3 months it's 2.3%. Now, the exact number may not matter so much, but the principle is important, that it's possible that these symptoms improve in time, slowly. So it may not necessarily be a permanent form of incapacity. So how do we then frame that in the way that we engage with people who experience these symptoms? Because a lot of their distress comes from not knowing how long this is going to last. And we don't know yet. We haven't had enough follow-up time to be able to tell. Now, one of the biggest studies, the studies that have come out, is the one that came out in January from China, where they used a cohort study where they follow people up over time, and they are able to present 6-month sequelae from patients who have been discharged. And for example, they're finding that fatigue is the commonest symptom, and it's in 63% after 6 months. After 6 months, when we had declared you to have recovered a month after your symptoms, or 14 days after your symptoms, we declared you have recovered. But 6 months, you still, 63% still have fatigue, and how that compromises the quality of life as well as the quality of work. And similarly, there is also this study by Davis et al. That shows something similar as well. And this one basically involves patients from different countries. And they are also showing that fatigue is quite high, and it's about 78%. And this is also self-reported. Now, I'm raising these things to say that the evidence is there, and it's enough, it is consistent. It shows that we have a serious problem. And we've also seen that, you know, in this study also by Davis, it shows that depending on the age, the proportion of people with long COVID will increase with increasing age. So among those who are less than 35 is about 26%. Those between 35 and 49 is about 35%. Those who are above 50, it's about 47%. Now, you're seeing that with increasing age, the extent of the incapacity increases as well. And also, as I said, that it looks like it may get better in time, but we don't know how long that's going to be. But it should not necessarily invalidate the personal experience. So let me pause here and basically hear your reflections. And I'm sure that as the day goes, you will engage even further with many of these discussions. But I'll hand back to you, Nhlanhla. Thank you so much.
Thank you, Prof, for that presentation. Do we have any questions?
I do have a comment to make. Just to introduce myself, Feda, I'm a medical doctor who got COVID last year in June and has been suffering from long COVID. And I just wanted to, first of all, thank you for it looks like you guys have done quite good research in terms of understanding long COVID. I just wanted to make a comment on the Dr. Dlakane's rehabilitation slide about fatigue. Because one problem that we've seen with the fatigue is that patients get post-exertional malaise. And what that basically is that after exercise or activity, 24 to 72 hours later, that's when you get hit by fatigue and a range of other symptoms. So in patients who do experience post-exertional malaise, graded exercise therapy may not be the best way to go. I might be able to do that thing today or do the exercises today, and then it worsens my symptoms for the next week. So you sort of have to take a pacing strategy rather than a graded increasing sort of approach. It needs to be an individualized thing. But yeah, that's the comment I wanted to make, because we want to help and not cause any harm or worsening of symptoms.
Thank you.
Thank you. You can respond to that one, Prof. and Dr. Sipho. If they, I think that was a comment.
It's a comment. It's a very good comment, and I think that it does actually raise question. It's something that we have to highlight, because when we are doing the graded exercise, we're going to look at the performance in that moment. We may not necessarily be thinking about what's going to happen 2 or 3 days later. So it's a very important point. And in a way, yes, it's true. You might go through the exercises, you might demonstrate improvement, but if it means that the patient is not going to be able to work for the rest of the week, you are basically negatively affecting other parts of their life. So it's something worth thinking about and highlighting. I accept that.
There is another question.
Absolutely agree with Dr. Ngwepe. I think it will be very important to actually individualize each patient's a rehabilitation program and see what the patient can manage and work with the individual patient. So absolutely take that point, Doctor. Thank you so much.
All right, thank you.
Thank you. There's a question there, although I think it's a generic question. Dr. Kalamesh from India. He says, how to prevent long COVID?
So the research that we have so far has looked at one, are there predictors of people who might have long COVID? But we don't have information that is clear about that. And what was striking for me in that literature is that people who may not have had certain symptoms can actually develop new symptoms in the sort of long COVID phase. And if we then use symptoms that they present with to represent what they may suffer during the long COVID phase, that may not necessarily be a true reflection. That is one. The second thing is that we don't really have genetic predictions of who might be predisposed to COVID or not. What we do know so far, based on the observational data that we have, as I said, is that there are people who would have more symptoms and they will increase with increasing age, or they will have more COVID with increasing age. Now, the best way, I think that I would argue that, okay, so basically when I discovered the story around COVID, the first thing that I said is that, you know what, then it means you must not get COVID at all. If you can help it. You know, at the time, you know, there was a whole lot of, there were arguments saying that, you know, let me just get COVID and be over and done with it. And so I basically said that, you know, this means that this idea of herd immunity by infection or just getting COVID and being done, it's not a good policy. We need to try and make sure that we prevent infection with COVID long enough for people to get vaccinated instead of actually experiencing the disease. That's what I would say for now. But I think I would also leave it open to say that as more information emerge, we might end up getting to know a little bit more. But that's pretty much all we know for now.
I'm actually quite glad that Dr. Ngwebe is actually with us, because there was one of the striking things. I think earlier on in the disease, it was assumed that it was going to be the older people that were going to be quite severely affected by the disease. And even on the presentation that I made, the age above 50 was also mentioned. But I think Dr. Ngwebe's experience and many other colleagues actually points to the point that people may have mild symptoms in the acute phase, but end up with a disease. And when I was doing my research for this presentation, I actually ran into Dr. Ngwebe's story, and I'm sure she can tell it better than all of us. But I think this is one of the important messages that we need to put out to the public, to say that just because you're young, it does not mean that you will not have sequelae from the disease. And the best prevention of this disease, of long COVID, is actually primary prevention, preventing yourself from getting the disease in the first place. That will be quite important. Thanks.
Yeah. So I would also take your point, Sarah. I think that, you know, this issue of, we've been engaging in a lot of debates about mild and moderate. And actually, the more I learn about long COVID, I realize that actually we must not dismiss the presentation of disease as mild or moderate, because the discussion has shifted basically, even in terms of vaccine discussions, to we need to be preventing severe disease and death. That's where the discussion has gone in all these debates around vaccines and what vaccines need to achieve. Yes, at the end, we want to achieve herd immunity, but in the scientific circles, that's the focus, is that we want to prevent severe disease and mortality. Now, what you're pointing out to say that actually these trials provide a platform for us to actually be looking at long COVID, including for mild to moderate, to be able to give it weight based on local data that exist, is something that should be taken seriously. And it might involve just amendments of protocols that have been approved for trials, for them to be able to follow up these patients down the line. So I take that point, and I also think that the issue of brain fog was also very important. I mean, a lot of the literature talks about the experience of cognitive dysfunction, and how do you actually explain that? How do you talk about that? How do you present that? You know, people know you, you know, at your work, you perform a certain way, and all of a sudden you are having cognitive dysfunction. And also, in a way, when I call it cognitive dysfunction, it could make it like it's a disease, but of course it's neurological impairment of sort. But also, on the other hand, to call it brain fog, people might just say, it's something mild, it's something small. but actually the disruption it has in one's life can be quite huge. So for me, again, it becomes important that, as I indicated already, that in the workplace, we need to be able to validate these experiences instead of dismissing them just because we don't know enough about them. And you can see that we are headed to a point where, to some extent, registering the diagnosis of long COVID would involve some sort of classification of either impairment or disability of some sort. People in occupational health might not want to hear that. A lot of the companies that we work for may not want to hear that. But at the end of the day, if you think about the number of people who may have been infected with COVID in a country like South Africa, and you start to imagine the potential for the impairment that would come from long COVID, even if it's 10%, it's huge. It's huge. And it's not just in terms of workplaces, also the disruption to people's lives in many respects. So it's not something that we need to keep on the sidelines anymore. We have to actually bring it to the center and talk about it. And that's the only way we can develop a plan and be able to put in place systems of support. The anxiety that is spoken about in the literature, a lot of it comes, and distress, and a lot of it comes from the frustration of having to deal with this new disability that's not recognized or acknowledged by anyone, but also just us not creating the space or the system to be able to support people who experience long COVID. So we really do need to move forward in that direction to make sure that we don't just talk about it, we put in place the actual systems. Thanks. I'll stop there and hand back to you, Nhlanhla. Thank you.
Hello, my name is Ondine Sherwood. It's wonderful to be here and meet all of you. I'm one of the founders of Long COVID SOS. I'm going to share my screen and show you some slides. Okay. So Long COVID SOS is a group set up in the UK for recognition, research and rehabilitation for people with long COVID. It's run by patients who met online in the Body Politic COVID-19 support group. This is an international group founded by a young woman from New York in early 2020 for people who had ongoing symptoms after initial acute COVID-19 infection. I founded Long COVID SOS with 4 other people in June 2020 because we could see that there were many people who weren't recovering from COVID-19. They were suffering alone in the community, struggling to get help, and we now have 8, soon to be 9 members. We started our campaign with an open letter to the Prime Minister and other health policymakers, where we asked for the establishment of a working group to commission urgent research, to develop care pathways, set up multidisciplinary clinics, as well as consider the economic and occupational health implications. We also made a film which has now been viewed more than 75,000 times, and which I hope you will have a chance to see later. We designed a website, built up a Twitter following, which is now approaching 9,000 people, and began to appear in articles in the press, spreading awareness about the condition. We also started to talk to researchers and to encourage them to start looking seriously at the long-term consequences of COVID-19. In August, we had 2 pieces of good news: a response to our letter from the Medical Director of NHS England, Professor Stephen Powis, and a contact from Maria van Kerkhoff from the World Health Organization. We held an historic meeting at the end of August with WHO. We organized speakers representing doctors, researchers, and patients, all of whom were suffering from long COVID. At the end of the meeting, Dr. Tedros confirmed that they had heard our SOS and agreed that patients were writing the first books on the condition. He asked us to maintain a dialogue with them, and we have continued to do this with regular meetings to help inform their response to long COVID. We have also been working closely with NHS England and are members of the National Long COVID Task Force. As you can see from this slide, they took the issue seriously, and we now have a network of assessment centres in England for long COVID patients. There is still much more work to be done, and unfortunately, the number of people with long COVID is growing daily. The government recently awarded £18.5 million in grants for research into long COVID, but we are still campaigning for more research into treating this condition. Later on, you'll be hearing from Dr. Melissa Heightman, who is a respiratory consultant and Deputy Divisional Clinical Director at UCLH. She was instrumental in setting up the post-COVID clinic at UCLH in London in May last year, where they now have seen more than 1,000 patients. And Dr. Deepak Ravindram, who is consultant in pain, musculoskeletal and lifestyle medicine and lead for the long COVID service for the Berkshire area. I will now hand you over to Janet Gunter, who is a co-founder and co-director of a small UK charity working on waste prevention. Prior to this, she worked with organisations in Southern Africa, specifically in Mozambique, on policy monitoring and campaigning. She fell sick with COVID in early April last year and will talk to you about her experience. Over to you, Janet.
So yeah, my name is Janet. I'm 42. I consider myself a pretty healthy person before April. I have previously, I guess my biggest health problem previously was getting dengue fever about 10 years ago. So I have a story of recovery from what I consider to be a difficult illness. But when I got COVID in April this year, I was actually doing quite a lot of exercise and feeling quite good. My story is, I think it's pretty representative of a lot of people. So there I am in the video that we made. I look at that and I think, wow, that was day 81. I was really naive about, I didn't know what was going to happen, but I was going to face much worse than I had faced at that point. So I'm going to walk you through my experience getting sick and trying to recover. And as you can see, I'm just one of a sea of people. So when I got the acute phase of COVID, I had a handful of symptoms, but none of the ones that would have allowed me to get a PCR test at the time, which is quite interesting. So I did not have a high fever. I did not have a cough. I did not have any of the symptoms that they required to get a PCR test, even later on when they made them more available to the public. At that point in time, I would have only been able to get a PCR test by appearing in the hospital. And this wasn't necessary in my case. I was suffering extreme fatigue. I had a headache, a very different headache than I'd ever experienced that came kind of through the back of my eyes. I tend to get just your normal stress headache coming up the back of my head in my head. I had a lot of muscle aches. I had a strange patch of skin on my face, which actually still hasn't really gone away. And that was it. I mean, it was basically like a bad flu, and I was in bed for maybe a week. I'm going to go through the course of my long COVID, but to start, I felt like I was recovering, like I recovered. So I spent that period of the acute phase in bed. I took some extra days or some time, but I felt like I was recovering towards the end of April. And I'll talk you through some of my main symptoms of my long COVID, which do very well map to this map of symptoms, which comes from, I believe, a survey in the United States. So maybe next slide, Undine. I've got the slide order a bit mixed up, but so help I received from the NHS was, and I first tried to access help 2 months after the acute infection, when I experienced what I would characterize as a relapse. So all of my symptoms came back in some form, and I found myself in bed again. So that's when I first reached out for help from the NHS. I didn't experience kind of disbelief or that classic kind of it's all in your head. I did, in fact, get some, tentative kind of diagnosis of post-viral fatigue or post-COVID syndrome. I had my GPs roughly explaining what pacing was and returning to activity. I got blood tests, I got an ECG, nothing abnormal, as it were, came out of these tests. I asked for a couple of extra tests for markers for inflammation and these kind of things, nothing came up. And I did eventually get a referral for chronic fatigue after making a bit of a fuss about that and finding out what the actual guidelines were. But that was in September and I've yet to hear anything. And I was encouraged also to seek out mental health help on my doing a self-referral. But again, the wait was extremely long. And okay, so this is more my timeline. And I thought that my leave calendar might help you understand how things went. So I fell ill on Friday, the 3rd of April. I probably took more days off than I logged on the calendar, if I'm honest, and I'll explain my work situation in a second. I probably worked a little bit less that week, covering my email and things. Now, as I said, I felt like I recovered. So you can see in late April, I was working. In May, I was also working. And this is when I experienced my first, what I realized later was post-exertional malaise. So I started going to the garden. So we have an allotment garden. And I almost blame the allotment garden for my extended illness, because there I was digging away in May and I experienced these crashes. So I would go and work in the garden and I would just end up on the sofa, unable to move after that. And I didn't really know what it was at the time. I just thought, oh, that's normal. I've been sick, that's fine. And then when I got this first relapse in June, this is when I took more sick leave and I realized something was really, really wrong. And then throughout the summertime, what I did was I kept getting these relapses, and some of them were correlated to my period. I started to notice this. And the week before I would get my period, I would relapse. And then in August, I had the most major relapse because I probably overdid it on what was supposed to be an actual holiday. And that basically triggered a really dark period where I lost a huge amount of energy, was really unable to continue on in the same way. And I started working part-time. I burned through, you can see I burned through all my leave. So the pink is annual leave. And by the end of October, I basically would have to either leave employment or come up with a new, or take extended, some kind of unpaid leave, or come up with some new arrangement with my organization. So I'll tell you what happened then. If we go through to the next slides. And the help I got from my employers, as I'm a co-director of my charity, I am still ultimately accountable to my board. They said that I should work less during the first 3 months. So this was a lockdown and many other people had to work less due to childcare with school closure. So that flexibility in the first 3 months was crucial from my employers to say, everyone's in the same boat. This is an unprecedented situation. If you need to work less, work less. After my relapse, they also agreed that I should go part-time, and that they encouraged me to take all the leave, take all the sick leave. And they understood that the time I spend on the screen, because my job is largely, home-based and screen-based, is still a cognitive load, and that it needed to be reduced for me to recover. So I handed over all of the project work that I was leading on to colleagues, and I worked much less. And I got their agreement to continue part-time working at that end of October, when the government opened up a furlough income support scheme that allowed employers to part-time furlough employees. So this was a savior for me personally and for my organization. And I'll go through, lastly, kind of the other help I got, and I guess I'll cover the symptoms and how I've been recovering. So the other help I've got has been mostly, I've been cared for by my partner, and this is literally, I did not have the energy to do the washing up, to cook food, to do shopping, to do basic life tasks. So without my partner, this would have been really, really complicated. And I really feel for people who are on their own. In terms of the online support group that Undine mentioned, it's really helpful to understand your symptoms and to understand that other people are going through some of the same symptoms. and to also start to identify patterns. So with me, I had extreme pain in my legs, and which is one of the main symptoms, and kind of a heart rate which didn't seem at all normal and caused me to feel really ill when I would walk too far or walk uphill. And I started to understand this as a bit like POTS or POTS-like. I understood that there's a whole body of knowledge about this condition and how to not make it worse. So that was really important. Also, I found more detailed information on pacing and chronic fatigue online. There have been a couple of really good resources on YouTube. Sadly, I found them too late to prevent myself from that major relapse in August. And had I paid more attention to that information, I probably could have avoided worsening my condition. And then there's a couple other things that I've learned about in terms of diet and supplements, mostly from this online support group, but also backed up by research or new research. And lastly, I just want to flag this, that had I not had the resources to buy an e-bike, I would be pretty much stuck at home for most of the past year. I really couldn't walk about more than a couple thousand steps, which takes, I can't even get to the store with those steps. So without an e-bike, I would have been really stuck at home. And also what's really proven to help me, and if this may be controversial among you, I don't know, but we've seen in our forum that a lot of people have also gotten help from homeopathy. And I've recently had a very good experience with that, which has helped alleviate a lot of my symptoms. But all of those things come at a cost, for sure. So for the first time, I guess, I'm seeing light at the end of the tunnel for me personally. I'm starting to feel my energy has come back. Some of the main symptoms I've been able to control, through diet and through some of this homeopathic remedies. But I do really fear for that we're not coming up with a solution for the people who are getting long COVID now, and that information to employers, especially about the condition and about the impacts it has, is not really getting out quick enough. And that there's a whole history of employers not dealing well with post-viral conditions or chronic conditions. And I'm really sensitive to the fact that in Southern Africa, it's a different context. I mean, here in the UK, we have people do suffer from post-viral conditions. They're largely either really misunderstood or hidden. And there's a real, I think there's almost a tradition of people poking fun or making fun of chronic fatigue and what it actually means. Whereas it would be interesting to hear from you, but I know that in Southern Africa, there's a much different experience with post-viral conditions. These are much more a part of potentially a lot of people's lives and lived experience. And I would hope that would lead to greater understanding in this instance, but this is something maybe that I'll wait to hear from you on. Thank you very much.
There's another question there. Probably can we take the questions after Dr. Deepak's presentations? Is Dr. Heightman still in the house? Janet, kindly confirm that I need to give to Dr. Deepak to give his presentation. Then we can take note of the question and then give ourselves 15 minutes before we close the morning session to take care of the questions.
I think Dr. Heightman had said that she would be not free after 10 o'clock UK time. So it is right now kind of rather 8 o'clock UK time. So I'm just not sure how that is. Janet, can you confirm, is Melissa going to come back in?
Sorry, are you talking to me? Sorry.
Is Melissa going to come back in or something? Because she'd sent an email saying she was only free between 9 o'clock to 10 o'clock UK time. So I'm assuming it may not be right now. Not
I'm in Nottingham, and I've sadly never met Dr. Heightman, and I don't
That's
know
fair enough.
anything
Don't worry,
about it.
that's all
but
right. Okay, then.
yes.
I'm happy to start off if that's all right with you, Lalna.
I think let's go ahead. We'll attend to Oli's question after your presentation.
Brilliant. Okay, then. Right there. Good morning to all of you and to many different parts of Africa there. Hello, bonjour. And I have stayed in Lagos many moons ago, so a little bit of knowledge there, but it's vanishingly small. I'm just going to share my presentation. If you can just let me know when you can see it. And many thanks to Long COVID, to Nalna and Bradley Research for having me. Can you see my screen?
Yes, we can see your screen. You can put it on presentation mode.
Brilliant.
Okay.
Right there. Good morning again. And my talk for this morning, and it's been set up very nicely by the previous speakers, Professor Moshabele and Dr. Dlakane, in introducing this. And I think I won't consider it a problem because I'm going to be repeating some of what they said, but I hope it'll be useful for many of you who are still understanding about long COVID there. And many thanks to Ondine and Janet for inviting me to be part of this really important juncture in recognizing this condition and providing support in a timely manner. What is my qualification in there right now? I'm the clinical lead for the long COVID service. So when 10 million were given by the NHS in October/November to set up long COVID clinics, 43 initial clinics were planned throughout the country, and I helped set up the Berkshire, so which is one of the areas which includes Reading. It's about 20 to 30 minutes west of London. And it's a lovely leafy part of the country in the southeast there. Worth a visit. It's very close to Windsor Castle for those of you who are touristy minded, not that we can travel these days. So I'm the lead for that service there. And I do have a certain other probably criteria which I think was helpful in setting up the service there. Apart from the lead service, I'm also the clinical lead for pain medicine at the Royal Berkshire Hospital in Reading. And I'm one of the few triple certified consultants in the UK with musculoskeletal and lifestyle medicine. And these all became quite useful and invaluable in supporting long COVID patients, recognizing that this could be a problem in itself. And I have a personal experience in the sense that I came down with long, or rather acute COVID at the end of March last year. It happened at a time, I think, when we still weren't aware that ethnic minorities were at higher risk. We just were starting to realize. We still weren't aware that long COVID would be a big problem. So I went through 10 or 12 days of a very difficult time. You know, I've had my share of man flu, but this was entirely different. This was really painful, and hats off for so many people who have suffered through the acute crisis, but then have struggling with long COVID, because we've got to realize, as Professor Moshabele said, that but for some unknown grace or you know, of God or immune system or whichever you call, it could be any one of us who could have had this condition of long COVID. So very important for me to realize that when I recovered from the acute COVID episode, I got quite interested in this phenomenon that I started to see in a lot of colleagues of mine in the hospital, as well as the reports that were coming out in the popular media, in Facebook, and in other social media networks about the persistence of these symptoms, and symptoms starting to far outlast the acute presentation that we've come to understand about viral infections. So I got the opportunity to be on as an author for one of the position papers, which we presented at the House of Lords. And that we'd like to think at least started the cascade of steps that resulted in more services being set up in the UK. And more recently, occupational health has been of use. And I think it's quite important that you're having this symposium and chat this today in terms of what's organized by Bradley Research, because me and my occupational health colleague at my workplace, we put out an editorial just come out this month in one of the journals in the UK. So I'm going to be focusing today, just going over a little bit around the clinical issues with long COVID, but then I'm going to be also talking about the long COVID service that we've set up here and how we've tried to reach out to patients, capturing some of the points that Professor and Dr. Dlakane have talked about, and Ondine and Janet have also mentioned about in terms of what would be needed. And then I'm going to focus a little bit on what I think are the workplace related issues, depending on what kind of employer-employee situation that's happening. So introduction to long COVID itself, where are we now? As far as the UK is concerned, we are looking at around 4.2 million cases as of, when I checked yesterday, 4.1 million cases for those who are being very pedantic about it. We have more than 120,000 dead. So that is our understanding that this disease is highly infectious is definitely a cause for mortality. But morbidity is equally important, and we realize that this is not your typical viral infection which goes away in 3-4 weeks. There are multiple sequelae affecting multiple organ systems, and we realize this dichotomy between non-hospitalized and hospitalized patients. We expected that hospitalized patients may have a worse prognosis and outcome, but what's been surprising is that non-hospitalized patients are indeed suffering a lot more. And certainly in the last 2.5 months of running the service, I can confirm that we have had a predominant number, almost 90% of our referrals into our service up to now have been patients who have been managing in community with relatively mild to moderate infections initially, but are struggling with symptoms now. So that's the condition we're looking at in there. What is long COVID? I think Dr. Dlakane and everyone has confirmed it. But for me, that set of questions, which I started to discover around June and July last year, culminated in working with Professor Tricia Greenhalgh, and we put together this kind of recommendations and priority research questions that must be looked at for long COVID. And Prof. Greenhalgh was able to present it at the House of Lords in September. And we'd like to think that that kickstarted what resulted in a series of announcements by the UK government in supporting patients with long COVID. The work of long COVID SOS, the patient support group, had become a really loud voice by then. So they were a powerful force as well in introducing the conversation into the public sphere. That resulted in 3 reports. In October, you had the National Institute of Healthcare Research report. In November, we had the NHS producing a guidance for clinics, and they wanted the clinics to be up and running by November 30th, December 1st. And Dr. Melissa Heightman's UCL clinic has been a trailblazer in this step. You know, she'd been doing the work already from June or July when the acute phase had come, and she'd had the research there. So hers was an excellent model to kickstart and at least present out there. And finally, this culminated in the guidance that came from NICE in December 2020. So what did the NIHR report from October suggest? That long COVID is not just one condition. They suggested that it might be actually 4 different kinds of conditions, which we are all putting under the umbrella of long COVID. So there's the one group of patients who have come out from ICU, who have had multiple organ problems, who have been on ventilator or a CPAP machine for some period of time. Then you have another group of people, which is the post-viral fatigue, which we are all fairly familiar with, that can happen there, but it was quite a big group of people. Then you had a small cohort of people who did have single organ complications, myocarditis or lung fibrosis or some form of microvascular thrombi that was affecting the kidneys or other organs. So that outcome and sequelae of that organ complications could be resulting in some dysfunction, cognitive or impairment or dysfunction neurologically. And then we had this big set of patients who were in the community, but who had fluctuating symptoms affecting multiple organ systems. And I think that is by far the biggest group, but these were the 4 groups that they recognized or suggested at that point of time in October. But what was common across the board was fatigue, pain, shortness of breath, brain fog and headache, mental health issues, GI problems, cardiac issues. These were the big ticket items. Even then, it had started to become realized. And the NHS guidance in November said that, well, most things should recover in 3 weeks. They put forward saying that, well, beyond 12 weeks, we could call it long COVID. And they said it might be a cluster of symptoms overlapping, which may change over time. NICE then became a little bit more clearer about it, and they actually specified that up to 4 weeks is acute COVID-19. From 4 to 12 weeks, they called it ongoing symptomatic COVID-19. So you may still have multiple symptoms, and that seems to be the case from a lot of the data that's coming, observational and patient-related data, is that a lot of patients do have symptoms going beyond 4 weeks, but it does settle usually by 10 to 12 weeks. But when it goes beyond post 12 weeks, they called it post-COVID-19. And for the purposes of the discussion, anything beyond 4 weeks, they classified it as long COVID. Now, long COVID, as you know, is a patient-introduced term, and it is one of the first times in medical literature that we have been able to take in a patient-supported and recognized term into the lexicon much quicker. And that is really a great achievement from what patients have been able to achieve with the power of their voice, their lived experience, and more importantly, social media. Now, what did the NICE guidance actually say? They were quite useful in laying out the land. They recognized that a lot of people are having symptoms from last February or March or even January coming through. So they realized that you do not have to have a positive antigen PCR testing or even a positive antibody test. You needed to have signs and symptoms that are somewhat consistent with COVID-19 infection, but as one person in the chat box said, asymptomatic patients could also end up having long COVID-like symptoms later, but that recognition was there. It has to last usually more than 4 weeks with no other organ problem or explanation to account for it. And it is a syndrome. It will affect multiple symptoms and systems, and symptoms will change. It was recognized that all age groups could be affected, even young children, young adults, and of course the adult age group would be affected. And it suggested that we should have a model for investigating it, management, and focusing on rehabilitation, taking into account the lived experience of the person. It should be holistic. It should have a good validated clinical screening tools and history. That was all what they suggested. And there were a few examples to go with. So what are the symptoms we were looking at? And that was a big issue there. Now, as you recognized from the earlier lectures, this is the broad thing. You had psychological issues that were seen in 76% from a study that the Royal College of GPs produced out there, a collaboration or synthesis of evidence as of October of last year. Fatigue was the big ticket item, 93%. Respiratory issues, breathlessness, shortness of breath, 83%. Pain, musculoskeletal aches and joints and muscle aches in 60%. Cardiovascular problems like tachycardia, palpitation, orthostatic tachycardia-like symptoms in 42%. And then you had a variety of other GI-related issues, diarrhea, constipation, loss of smell, loss of taste, brain fog, cognitive issues, all of these were there. Broadly, I tend to think of it as short term, you're likely to have many systems involved. But when you go beyond 6 to 12 months, invariably fatigue, pain, and psychological issues like anxiety and depression are the main issues there. What is the cause? Well, some of it was mentioned by Prof. Dlakane, but for repetition, right now we can't be absolutely sure. But what we think is the predominant issue is an hyperactive immune system. Now, fundamentally, if you think about it in acute COVID-19 as well, the spike protein is not necessarily the damage creator. Of course, it can enter into more cells, and that seems to be one issue for infectivity. And the South African variant from the mutation talks about the increased infectivity because of the way it can get into more ACE receptor present cells. But that's not the issue really. It's how your immune system responds, and that is almost unique and personalized. How exuberant an immune response you mount and how much of a balance your body can actually bring back in will reflect on the final outcome. And in some people, that immune response becomes so exuberant, so hyperactive that it starts to cause collateral damage. And that causes the acute cytokine storm that ends up leaving acute people in hospital. But we think that the same kind of dysregulated hyperactive immune system could be responsible for the multiple organ systems continuing to be affected in long COVID. There are suggestions that there may be still the presence of some viral fragments or remnants in the olfactory bulb or in the gastrointestinal area. There may be a possibility of relapse and actual reinfection, so that is a possibility. Deconditioning, the lockdown effect, social isolation, post-traumatic stress, these all could be contributory factors to new onset anxiety and depression. Newer theories that are coming up based on how metabolism and energy production and mitochondrial effect can occur is when you have mast cell release with histamine being an issue, or NAD plus deficiency has been mentioned before. These are all evolving areas where there is biochemical plausibility, but it is still yet to be proven in proper causation, though there is good correlation. Who is at risk? Well, any age group is at risk. We thought initially it would be older people, more chance, but I can tell you that in the last few months of running the clinic, it has been predominantly the working population, predominantly fit and active athletes and triathletes and people who are otherwise, like Janet's case, completely fit and healthy people, part of your working demographic, who are being struck down the most. And I think that is something we must be cognizant of and take into account. Generally, higher BMI has been noted, and women have been thought to have more history of having it, or risk of having long COVID, whereas men are supposed to have much more higher risk of being admitted into hospital because of acute COVID. So they have a more severe infection, but women tend to have possibly a lower risk of acute, but a higher risk of prolonged long COVID. But this is still just correlation or observational. So how do you then design a service, a clinical service, with what NICE has suggested, with what patients we were seeing, with such varying symptoms there? And that was a challenge. That was something we needed to work on. And we had to realize, well, what are the numbers? You know, how do you decide when you want to decide to set up a service, as in any of you? At the end of the day, it is still a business model that has to come through. It has to be clinically effective, but it also has to be financially sustainable for a model or a healthcare system to set up. And we realized that we had good numbers when it came to people who are admitted in hospital, registry data, statistics. You could get good numbers of people in ICU or in hospital, but it is the moderate and the mild symptoms that are in hospital or present to A&E or to community health clinics that are difficult to quantify because we don't have a central system. Certainly in the UK, we don't have. I'm not sure about our various African countries. I presume it will be the same kind of logistic problem that's there. So counting numbers and having an idea of what kind of service, how much is the footfall, what kind of numbers you need to be prepared for. We know that from our data that the mild to moderate are going to be the biggest challenge. We think that 10% of the population, according to the data now, are likely to be left with long COVID. So if you think about it from the UK perspective, and you could have the same data for the African countries that you are in and listening to this, that if 4 million UK cases have been positive, we are expecting close to 400,000 cases of long COVID in the country. Now, is that an overestimate or an underestimate? Don't know, but that's what the numbers we could be looking at. And that means that is a bigger public health issue than all the excess deaths that we have been talking about or listening to in the media and in the news. That studies, in order to search for numbers, we did have some study from the ICU groups that were put out in Bristol and Leeds after the first wave that we had in the UK from February to about June last year. And the study from Bristol suggested that fatigue was there 3 months later. The study from Leeds, which was about, again, 4 months later, suggested that fatigue and breathlessness was the main issue. And then we had this studies from previous SARS epidemics in Canada and Toronto, where it was much longer. So we had some data from beforehand from other epidemics, which suggested that when you looked at 1 year or 2 year data, chronic widespread pain, fatigue, depression, sleep, psychiatric issues were going to be the main problems. And this has been shown by finally with the study and data that Professor Moshebele mentions from Wang et al. And Lancet, which talks about fatigue in 63%, and the Davis study, which talks about fatigue in 78%. So that is going to be the biggest issue that employers have to take into account. Occupational health physicians who are in the audience listening to me will have to take into account. But it is also a sinister issue because when they did a study in Hong Kong looking at SARS survivors 4 years later, 40% still had active anxiety and depression, 25% had chronic fatigue-like symptoms there. And the risk factors are at that time is if you're a healthcare worker, if you're unemployed by the time follow-up occurs at 3 to 6 months, if there is a stigma, a social stigma that you're not being recognized or validated or being listened to, then that is all going to be risk. So the challenge for all of us as employers, occupational health, as doctors, as healthcare physicians, as patients here, is how do we support each other at this time? So the ways forward, I would suggest from the experience that I've had up to now is to discuss with your local healthcare systems in your countries as to what kind of case mix that you're having that are presenting in hospital and whether you can pick up any kind of community data. We had a Public Health England in UK giving us some suggestions that, for example, in Berkshire, we were going to have 1,300 cases of possible long COVID based on some statistical modeling. For our area, with the population of around 500,000 that we have in Berkshire, we were told that we would have roughly about 1,350 as of November 2020. So that is pre-first wave data. As you know, we had a much worse second wave starting from about December, and we're just coming out of that now. So that may change how the numbers are finally. But you have to realize community burden, not just the hospital mixed data which you'll have, but recognize that community burden is going to be a big percentage, and that will add a substantial proportion when you're thinking about how to set up a service or how you're going to interface with the service there. LAD's review from December has been very useful. They've talked to a lot of patients, 114 patients, a qualitative study, and they said that essentially we need to ensure access to care. We need to ensure that we reduce the burden of illness, and there should be some element of clinical responsibility to provide continuity of care. It should be a rehabilitation that's multidisciplinary. There should be the ability to investigate, assess, and manage certain organ complications if it is picked up in patients. At the same time, there should be an ability for this patient group and those symptoms to contribute to some form of research or knowledge-based development. So with all of this there, this was the data that was available at the time of setting up a service. And I think when you're thinking about it in Africa and different parts there, these are some good models. Dr. Heightman's model in UCL has been brilliant. I'm going to be talking about what we helped set up in my area here. So the Berkshire Long COVID Integrated Service, that's what BLISS is. That's our registered long COVID clinic in Berkshire, of which I'm the clinical lead. We wanted to embrace all those principles. We want to have the holistic multidisciplinary option. We wanted to make sure that it is suitable for both hospitalized and non-hospitalized patients, children and adults, management and rehab, referrals from primary and secondary hospital care, and wanted to have the basics for the diagnostic test that NICE had suggested with good consultant and specialist input where required, and more importantly, ensure that there is equity of access, try to reach out to whichever population we need. I took great precautions in making sure that it has co-produced. So I did reach out to the long COVID group and ask them what would be the things that would be needed to be included in service. And we've tried to include as much of that information into our service so that we can make it as patient-centered as possible. There have to be obviously adjustments with what the financial envelope that we had to set up that kind of a service, which came down from the NHS. But we had to be innovative. It has to be very different from what you've done up to now in setting up services, because you're dealing with an emergent strategy problem of unknown numbers, evolving numbers, growing numbers, different symptoms. So it has to be agile, it has to be innovative, you have to find a way to think about financial sustainability, and you have to include treatment and rehab, because like most healthcare systems, the NHS is already strapped. There is a lot of mental fatigue in healthcare workers themselves. So we can't, after assessing these people of long COVID patients, you can't just put them into the back of a waiting list of already existing services. There must be a way to provide services to this group of people that are aimed at getting them back to their quality of life, rather than just leaving them there and say, okay, you're fine, you've had this, it's nothing. Now you wait in a chronic fatigue service line, doesn't just crack it. We wanted to make sure it integrates physical and mental health, And more importantly, I'm very interested in the concept of trauma informed. We are realizing that all of us have gone through a trauma. Even if we have not got COVID, we've all known people who've got COVID and we know how it has affected our life. That is all a kind of trauma, psychological, physical, emotional, and that takes its toll. And return to work becomes hugely important because these patients are all working class people, not working class people in the sense, people who've had professions, jobs, careers, family breadwinners, and now they aren't able to do that. So we have to ensure that we have a robust system of how to support them back into the workplace. And that means commissioning or a value-based healthcare is a good model to look at. So we sat Bliss in the tier 2 and 3. You had tier 1 where the GPs were going to be supported and they could manage the really mild patients. And there was a UK-based Your COVID Recovery website recognized by the NHS, which provided some website-based support there for some patients. But tier 2 and 3 is where long COVID integrated service sat and helped. And of course, we had access to specialist input where required. We had a GP with a specialist interest in long COVID and who had worked in the respiratory hub to help us. I was there as one of the consultants offering the medical input there. We had a fatigue and pain physiotherapist and a respiratory physiotherapist because of the most common nature of problems that come to the patients there. We had an occupational therapist working to see how we can ergonomically assess and help some patients in terms of their workplace adjustments if required. We had access to a psychologist and talking therapies in the UK and psychiatrist if required. And we had access to, of course, other specialists if such problems came up, cardiology, respiratory, neurology, psychiatry, and then rehabilitation medicine as well. We have digital options which the NHS has approved in terms of Your COVID Recovery, a Leicester-based app. We are thinking, and this is all evolving knowledge and still learning, as we said, because primarily it is still symptom management. There are no clear curative drugs. We can talk about niacin supplements. Janet has talked about homeopathy. I've had patients who have had benefit from a variety of Ayurveda or homeopathy or other traditional herbal preparations there. There's suggestions that H2 blockers might be useful if there is histamine release or mast cell activation in there. There's suggestion that hydration or use of some beta blockers might be useful if POTS or orthostatic tachycardia or cardiovascular symptoms are present. But this is still observational and correlational, evolving. Research is happening, but we don't have clear-cut drugs to prescribe. So that means a lot of it is around supporting patients in a scalable manner, which can be done. So digital and technology has come to the help, but we have face-to-face group programs, which we are going to start. Right now, it's all Zoom, like I'm talking to you now, but we're hoping to have some face-to-face starting in another 1 or 2 months when it is safe to do so. And then, of course, we are reaching out using charity funding options to try to provide within the community other mind, body, and well-being therapies like Tai Chi, yoga, hydrotherapy, mindfulness-based strategies, meditation, because all of these rewire the nerve circuits, change the kind of inflammatory and stress molecules within the spinal cord, within the central nervous system. So there is scientific study to support their use in a condition wherein we know that there is neuroimmune dysfunction. As I said, with long COVID, we think of that there. So what do we do? All of this information needs to translate into some form of occupational health supportment there. And in this, I have to thank my colleague, Blandina Blackburn, an occupational health physician in my hospital and a national figure in the UK here, in terms of the editorial we put out this month. But we did identify that with occupational health, these are all the issues which are going to implicate or have an impact on employee return to work. And as employers, we need to be cognizant of the fact what lockdown, what local restrictions does, what working from home with poor ergonomic preparation could do to your pain, to your psychological workup, and to your ability to recover from the condition. The distress that is going to be there because of all this in some of the countries that are worse affected in Africa. Of course, there might be organ complication with structural changes in mild to moderate cases, which we haven't discovered. Now, it is very rare, but still, it's not known whether that's a possibility. And of course, ongoing other organ system issues over there. Now, deconditioning and musculoskeletal pain also could be an issue. So in all of this, as one of the chat people asked, prevention is hugely important. There is no absolute reason to not be following the safety guidance, and it works for the same. Occupational health physicians should be looking to work with employers to encourage employees to still adopt safety guidance. social distancing policy in place, to provide PPE where required there, and to encourage rapidly a good vaccination, because we know vaccination at least reduces the risk of serious disease. We do not know which person's immune system is going to be providing an exuberant response to when COVID attaches or attacks. So there is absolutely no reason, for me at least, I would say that vaccination needs to be encouraged there. I know that this is still a dicey and a difficult topic with a kind of vaccine misinformation that's going on in social media. But for me, it is crystal clear that vaccination is going to be very important in reducing the chance of severe disease or reducing the chance of problems of hospitalization. So I think that is definitely something to be taken in mind. What are the needs from occupational health perspective there? Awareness, not just among yourself, those of you who are occupational health physicians listening to me right now, awareness of the condition. You had 2 talks this morning, so I hope you are more familiar with what are you likely to face, the many facets of the condition and the varied symptoms, and then the blood test and the investigation. Now, NICE has given us a set of what must be done in primary care or as a part of investigative workup. You may have in your country a different set that's been suggested by your regulator or health body, but please become aware of that there. Knowledge of local clinical pathways of services that have started and how you can integrate and interface and work with colleagues in that pathway to dovetail with what they are saying, because it's important that we sing from the same hymn sheet here. And then what can the employer do in terms of actively adjustment, sick leave, compensation, pay packet? These are all important discussions that need to be had proactively rather than doing it reactively. And at the heart of all this, employee well-being is paramount. What are the online resources that you can tap into to provide access to your employees in the workplace? And what are the various offline and community support systems that you can harness to provide this support out here? Social support groups, social media, all of this needs to be brought into place. In our editorial, we talked about the role of the occupational health physician as being paramount in understanding and making adjustments and to aid both the employer and the employee in setting up a system on what should be the way people can return to work. It's a great way Blandina has made this statements there. But broadly, if you look at it, fitness to work, well, what is the primary role of that employee? What are the redeployments that that employee may have to make given the industry, given its healthcare or oil or gas or mining or whichever kind of occupation they are in, how close proximity they may have to work, which can increase the risk. What are the issues around volunteers? You know, when, for example, in hospitals in the UK and healthcare, we've had volunteers who have been elderly wanting to help out. But then if you're getting elderly people working out, what's the responsibility of an employer to ensure that they are not at risk of catching the infection because they are reaching out to do something? What kind of risk assessments need to be in place? What are the workplace adjustments you need to do for your employees sitting at home? There was a study that came out in Finland at the end of the 2000s, which noted a massive increase in back and neck pain, which caused a huge pressure on the system down. And it was correlated to the fact that teenagers and people started to have access to internet and computer sitting. Imagine the amount of time you're all sitting and listening to these lectures over the time. Imagine the amount of time that you have spent on Zoom and all these webinars over the last 10 months or working from home on extended periods of time. Are your employees ergonomically adjusted when they're sitting in workplace? Are you actively advising and encouraging them to not sit with an iPad or a laptop in bed with a tub of chocolate in their hands? That's very important there. We've talked about the responsibility of how to encourage with long COVID patients that graded return is not really the way forward. Pacing has to be taught. There are some excellent resources on how pacing needs to be done. We can't use the graded return to a phased return to work thing necessarily when fatigue is a big problem here. And of course, the role of the employee and redeployment in terms of how you then adjust to different workplaces or different departments. For example, a person who does a manual work, you may have to do the workplace adjustment if he's going to be redeployed to do duties in a different place where the fatigue and the pacing can be managed more effectively to still keep them productive and supportive to their family and to the economy. lastly, but not least, psychological support is paramount. Well-being pathways need to be put in place by occupational health physicians. It has to be at its heart a compassion-focused basis. There needs to be validation and listening to approach. And at the end of the day, about all this, care starts at home. Are you yourself looking after yourself first, because you are going to be at same risk of burnout as the employees or at the employers that you're helping to. This goes out to all the occupational health colleagues. So I leave you with these questions. As with long COVID, we've understood there are going to be more questions than answers, and it's an evolving field. But the questions I would leave you is, should it be an occupational disease? 7 or 8 countries in the Europe have already called it an occupational disease. UK still hasn't done it as yet. What about African countries there? Are you going to ratify it as an occupational disease? As one of Dr. Dlakane pointed out, should we be making it a proper? I think definitely it should be recognized by governments as a disease entity in its own right to be eligible for funding in there. Compensation is another thorny issue in terms of healthcare settings there. It's been talked about in Europe and in our UK, but I don't think we've come to any clear consensus. Definitely, I believe there should be training of managers and employers regarding all these issues that you've heard about now. How will it impact on staff training? You have a lot of patients with long COVID or various workers or employees. How are you going to adjust with other staff members in terms of impact on training and how the general morale of the workforce is going to be when you have different workforce populations with different issues? How do you capture that, and how do you mitigate the risk around that? And then most importantly, how would you know where the person has caught COVID from? You may think it's workplace, but is it really? I do not know. It's difficult for us to know and be absolutely sure. And at the heart of it, how do you finally avoid penalizing people for what is certainly not their fault per se? But these are all the thorny questions. I'm going to leave you with an open for further discussion, and I'm happy to answer and take any questions. Thank you once again to Bradley Research and Long COVID SOS for having me today.
Thank you, Dr. Deepak, for that insightful presentation. Let's try and attend to the questions that that are on the chat group. Let's begin with the one that we packed from Oli. Oli, you're still around. I can see you. Would you want to unmute yourself and raise the question, or we should read it and then one of the facilitators may respond to that? Dr. Deepak,
which one is this, sorry?
From Oli, before we can go to John.
Okay, I was a COVID specialist nurse and developed COVID 275 days ago, developed PTSD symptoms and night terrors. Do we think it's connected to autonomic nervous system? First of all, I think night terrors or PTSD has been recognized as a possible complication or effect of I wouldn't say long COVID, but it is an issue of a variety of factors. You know, you have said it's a specialist nurse there, whether your role as a healthcare worker, what you've been exposed to, does it put you at higher risk? That's all possible there, definitely. In terms of mechanisms, I would agree with you. I think the evidence for a lot of these post-traumatic stress or chronic traumatic stress, there is a suggestion that there is neuroimmune, low-grade central nervous system inflammation that goes on in various parts of the central nervous system and spinal cord. So whether these kind of microglial inflammation or CNS changes is contributing to an autonomic system dysfunction, and that is causing these things, it's a possible likelihood, but I don't think I have definite causative research to help say it is. I would agree with you that autonomic imbalance, this could be a presentation of an autonomic imbalance that's there. And the treatments, though, do not really change. If you are having PTSD-like symptoms there, then I would encourage you to look closely locally for psychological support first off to start with, and maybe explore other options like EMDR therapy or tapping or other kind of somatic experiencing or somatic movement techniques, which are starting to become more prevalent in different parts of the world.
Thank you for that. As well as being a COVID specialist nurse, I'm a trauma-informed massage therapist with women in the asylum system. So I do know you know, the trajectory of trauma, but this, I am actually now in trauma therapy myself, but it feels like it's beyond beyond words. It's beyond, it feels like a physiological, you know, you get waves of terror in the night that wake me up, but it's not attached to dreams, it's not attached to thoughts. And that's what made me think it's probably autonomic nervous system dysfunction, which leaves me then thinking, well, what helps? I don't really want to be on medication, but actually all that I know that would help, yoga, mindfulness, breathing, everything I taught myself down at night, doesn't really stop it happening. So, and I know I'm not the only one, but just interested.
I would probably, sorry, is there an echo somewhere? So no, I would probably say that I think from the reading, and this is going slightly out of context out here, there, it's not something I generally suggest out there, but I read a very interesting book towards the end of last year called The Angel and the Assassin by Donna Jackson Nakazawa. And in that she talks about, and then of course there's I think another book by Matthew Walker in Why We Sleep, where he talks about the fact that this autonomic dysfunction that can be underlining PTSD, because once you've got night terror coming along and you've got that release of adrenaline from the central nervous system, that's got to enter into the rest of your circulation. So that's going to then drive the lower kind of inherent reptilian or lower pathways of autonomic imbalance and heart rate and sweating and all the autonomic changes. So they were talking about prazosin or alpha-1 blockers as medications to be considered. And there's been some good trials, 1 or 2 trials talking about the role of prazosin, and I think one other alpha-1 blocker that's been used for that kind of pharmacological look at PTSD. In Donna Jackson's book, Nakazawa, she talks about microglial changes. She talks about a couple of other therapies to look at how you can rewire or calm the system down in addition to the therapies you're talking about. She makes mention of something called the fasting mimicking diet, which takes into account intermittent fasting regimes to give you that kind of anti-inflammatory effect that lowers further any kind of neuroimmune inflammation that may be occurring at the microglia. These are possible avenues to explore, but I agree with you. This is quite tough, and I can't imagine that, you know, it's an easy time for you.
Thank you for your response. I have tried, I did 100 hours of fasting, nothing shifts it, which makes me think it is autonomic nervous system rather than, but thank you for your response, I appreciate that.
Thank you, Ollie. John, your question says, probably question or comment says, COVID-19 is deemed an occupational disease in South Africa. How do you definitely state that it was contracted at work? For now, long COVID is possible being considered as an occupational disease. What's your viewpoint? I saw Dr. Mpofu as well. Dr. Deepak, you can go first, and then Dr. Mpofu, you might also want to come in and respond to that. I
think long COVID has been recognized as an occupational disease in about 7 or 8 countries in Europe, if I'm not wrong. That's what Dr. Blackburn Blandina told me a few weeks ago when we were preparing the editorial. I think UK, there's still discussions going on there, but I have a feeling that there has to be some kind of changes that will happen. I believe all of this is related around what are your healthcare systems or employer-based systems, how they are set up, defines on occupational disease classifications. And I think this changes from country to country, my understanding, but I hope Prof has, or maybe somebody else has got a better opinion on this.
Dr. Mpofu, your comments? You can unmute yourself, Dr. Mpofu.
Yeah, I'm just trying to.
Yeah, we hear you.
Can you hear me?
Yes, we can hear you.
Yeah, in South Africa, because we've got a system that is a risk model that is based on risk. And one of the things that is there is that, because the health workers are working in a hospital, and the assumption is that, the exposure to COVID it's quite, it's almost more than, the general population. It's taken as what is that, an occupational disease. But again, it will be based on individual, again, going to individual, to specifics, the risk, how long he works in the hospital, the shift, and again, it's all about exposure, and risk. Thank you.
Thank you, Dr. Mpofu, for that comment. Dr. Dlakane, are you still around? We just need to respond to the questions that what would be the best way to treat the lingering body aches? Because I am very weary for the use of anti-inflammatories. There's a question by Lorraine. Lorraine is an occupational health nurse. Can you kindly assist in responding to that question?
Would you like me to go, or have you asked someone else, Nalla?
You can go ahead, doctor.
I'm just looking through and finding that there. Just can you repeat that again? Is that pain of musculoskeletal aches? Is that what you're saying?
No, that's not the one. Let me just go back to the question. I probably could be missing it now.
No, because I can see some things from Dr. Kamlesh Sarkar and Kerry W, but I can't seem to find that musculoskeletal aches and pains. A lot of things with aches and pains in this scenario could be because of two reasons. One is the sarcopenia that comes because if you've had a fairly acute problem with COVID-19, then the fatigue and the relative tiredness leads to a rapid change. Studies have shown that within 1 or 2 weeks of being really fatigued and tired, your muscle mass changes and fat starts to come into place instead of your muscle mass there. So that sarcopenia could be contributory to aches and pains that will start off. The second is the same construct of neuroimmune inflammation that I talked about in the central nervous system could also be happening in and around the muscle fibrils and at the tendon points there. So that starts to have joint aches in there. So both of these are reasons. I am of a more holistic approach in the sense that if you are going to be keen not to looking at drugs or anti-inflammatories because that may not be suitable in many people, then you really have to have a much deeper focus on a variety of diet or mind-body regimes. And the reality, as Ollie has pointed out, it's not an easy time. It takes time, it takes practice, it takes a few weeks to a few months of sticking to that diet and sticking to those regimes. And that's not easy. It's easy for me to say, I understand, but it's difficult for everyone to practice. But that's what we are suggesting, or I would recommend.
Thank you for that response. I think one of the critical questions that that this audience would love to hear is around pre-employment medical examinations, and how do we deal with those in the context of post-COVID? How do we assist our occupational health practitioners deal with pre-employment medicals when it comes to a person that presents with a long COVID? How can we assist? What could be our best approach to such a situation?
So I've had a thought about this and discussed this as well. I'll say my point of view, but I think this is still evolving there. And if someone else has got a plan of action that seems to start to work well, I'd be interested to hear it. My thoughts are that we should be investigating initially. So if you are tapped, for example, if that long COVID patient has been in a service where they have had a set of investigations that have been done. So for example, in the UK now, if in Berkshire a patient is going to be going for a pre-employment check and has got long COVID, then that person might have been through my service. At least then the occupational health physician or practitioner in place would be able to potentially, with consent, reach out to us, get the data there so that we have an initial understanding that this patient does not have any structural issues, any organ complication, and has generally come out on most tests as not having any significant medical issues. That is not to say that they are not having the symptoms of the fatigue and but then that becomes a discussion then for the occupational health practitioner to look and say, well, we've got a productive employee who's capable of a lot more, who is going to recover and be of value to the company. How can we then put the adjustments in place, or see how we can introduce pacing and other strategies, well-being strategies to put in place to get this person gainfully employed? That would be the discussions I would be looking at. So that kind of investigative profile is now available in the UK, and maybe that's what different countries would have to look at in Africa as well when you set up your services. But otherwise, as a baseline, some element of investigative workup is provided by NICE, and that could be a template to start off with.
Thank you, Dr. Deepak. I think what we'll do, we will also send the NICE guidelines to all participants. I think they are very well documented in terms of giving guidelines as to how you can manage long COVID.
I think it's a good enough start. NICE recognizes, and they call it as a living document. They also realize that evidence is going to keep coming and it will change over time. But as a starting point, they have done a decent job of putting it in and putting it together and making a good holistic recommendation. So I would highly recommend that as a starting point for anybody wanting to take anything there. And of course, there are excellent models like UCL and mine to at least take the good things from us there and improve on what we can improve and make it better and more adaptable for your area there. Now, Janet, actually, just as a last point here, Janet makes a very important comment there that yes, when it comes to diet and all that, a lot of GPs in the UK are very skeptical. And I think I agree that in Africa and in India as well, it's the same issue. And I would actually, I was educated in India and I've been in the UK here, and I know what I was taught in my medical school back then and in here. And I would have to say that in the last 10, 12 years, as part of my preparation for my book, The Pain-Free Mindset, which I wrote, there is absolutely a sea change in how we understand neuroscience, how we understand the role of nutrition, the microbiome, the diet there. So I'd actually say, yes, the GP's skepticism is probably valid, but they are coming from a place where they wouldn't know that this is now valuable knowledge to incorporate. And I think there are a lot of GPs, and in Africa as well, where lifestyle medicine takes into account this new knowledge of how nutrition can make a difference to long-term condition management. And that's what we need to think of as long COVID. It is now a long-term condition that we need to look at, much like diabetes and asthma. We do not have a clear endpoint or a single cure. So the aim should be to do what is required to enhance quality of life, get people back to thriving and living, rather than, saying, oh, you should have got better, now sort something out for yourself.
Morning, Nhlanhla. I just want to add to Dr. Ravindram's points that he's made here. I think for all of us in Africa or in Southern Africa, we're really learning a lot. And I think the greatest lesson that we would have learned from this discussion this morning is that we're going to need to start a lot of collaboration. As you recall that from my slides, one of the points that I made is that it's actually just to get the clinicians, first of all, to recognize this as an entity, which I don't think a lot of awareness is there. But I think we've learned a lot, and we are probably going to start a networking with our colleagues that are with us here to actually push this way forward so that we can educate ourselves, educate the medical fraternity so that we can help our patients. Thanks.
Thank you, Dr. Dlakane. I think we are down to our last 10 minutes. I wish to give the last 10 minutes to Dr. Heightman to give us her presentation just in less than 10 minutes, if she's available. Dr. Heightman, are you around?
I'm here. Can you hear me all right? Can you hear
Yes.
me? Brilliant. So hi, I'm Melissa Heightman. I'm a consultant at University College Hospital in London. I think I might have joined late. I'm sorry. I thought this started at 9, but I have just got a few slides that I could share with you about how our clinic evolved here. Can you see these all right?
Yes, we can see your
Brilliant.
screen.
So I think we need to finish by 9:30, do we?
Yes,
Okay.
according to UK time, yes.
Okay, sorry, yes. It's actually quite sunny in the UK today for once. So, okay, so I shall let you know, we started our clinic back on the 11th of May and initially using a van outside the hospital because outpatients was shut. And fortunately, we're now back in the building, but that just shows you the hospital at UCLH. We've had over 2,000 appointments now, and you mentioned that this is an occupational disease and 15% of our cohort are NHS staff. At the time, it was difficult for patients to access care. So we had a very inclusive referral policy. We took patients from hospital discharge or from our local GPs and offered a one-stop assessment with doctor and physiotherapist. And included an exercise test in that, and then some same-day diagnostics such as echo, CT scan. And we really learned at pace. We definitely didn't expect to see what we were seeing. We thought this would be a respiratory disease, but in fact, it rapidly became apparent that it was quite a complex syndrome and slightly different in patients who'd been non-hospitalized compared to those discharged from the hospital. And we tried to develop management plans, which initially was quite focused on self-management, psychology support, rehabilitation with physical therapists, physiotherapists. But as we've understood the condition better, we're starting to now use medication for some of the sort of traits that we see, using a lot of collaboration with other specialties to try and help us with management of the sort of really complex multi-organ involvement that makes up long COVID. And we're serving a population of 1.6 million people. There may be up to 9,000 patients with long COVID symptoms at 12 weeks, according to our Office of National Statistics estimates. So clearly this is an immense problem for our healthcare system. We're working quite closely with community partners to find ways to develop integrated pathways for patients and to make sure that access to assessment is equitable. And this schematic just shows the sort of phenotypes that we see within our long COVID clinic. We now think of long COVID as a combination of end organ damage and then other phenomena. And you do also see sometimes exacerbation of pre-existing comorbidities in a patient. So it creates a really complex picture. There's obviously, these patients are quite distressed, partly by the pandemic, partly by the severity of their illness, the longevity of it. And I think they do need psychology to support to help cope with their difficult symptoms, but we would not consider this a psychological disease in any way. So these are the kind of patterns of change we see. Obviously, in terms of symptoms, fatigue and breathlessness are very dominant ones, also chest pain, palpitations, brain fog, which goes along with fatigue, so that cognitive the cognitive processing problems. And I think what's been a surprise is the prevalence of autonomic dysfunction that we see within this group, a lot of orthostatic hypertension, so, postural drops in blood pressure. We see quite a few patients with POTS type symptoms. And that seems to drive other symptoms in these people, such as chest pain, and contributes to, for example, quite a few of our patients were reporting desaturation on walking, which was very confusing at the start because we couldn't identify obvious cardio or respiratory pathology that would account for that. We think now that that's probably something we're seeing particularly in people with autonomic dysfunction. We have been doing quite a lot of walk tests on these patients to try and understand, their breathlessness better and their exercise physiology. And some patients definitely have a very reduced anaerobic threshold, which, as my colleague was saying, as Deepak was saying, that is probably multifactorial, you know, partly due to deconditioning, but it's so marked in some people. We're also wondering about mitochondrial dysfunction, as whether that could be a contributing mechanism. We see quite a lot of evidence of disordered breathing pattern, which is a diagnosis made by our physiotherapists, and whether that partly has a physiological explanation or is a response to their acute respiratory illness is a bit difficult. Obviously, we do see myocarditis, we see some interstitial lung disease, venous thromboembolic disease, and because we look after our post-hospital patients, we also have a cohort with severe post-intensive care morbidity, relating to sort of critical illness, myopathy, problems to do with the prolonged intubation and tracheostomies. So we have learned that it is not a respiratory disease, and we've pulled in help from a number of other specialties. So now the way we run our services, we have some clinic consultants and therapists who do the initial assessment and work out the diagnostic plan. And then we have a weekly MDT where all these lovely people get together, the cardiologists, neurologists, hematologists. We've also got rheumatologists joining us to try and better characterize what we think is going on and develop a management plan. And the patients are surprisingly unwell still. You know, this is very early data. I need to catch up with my graphs because we're now seeing some patients at 9 months after follow-up. And about 50% of our non-hospitalized patients are still very unwell at 9 months. A lot of them have significant breathlessness, MRC score of 3 or above. This is the sort of spectrum of symptoms, so dominated by breathlessness and fatigue, but a multitude of many other symptoms. And as you said, very much a huge impact on their ability to work. So a quarter even of our non-hospitalized patients were still too unwell to work at 6 months post-COVID. And those patients who were still unwell at 6 months seem to often still be unwell at 9 months. We haven't quite seen the rate of improvements that we hoped. We thought we were seeing that, but this turns out to be a very fluctuating recovery period. So patients can have relapses after an apparent impressive improvement. We're now developing a sort of integrated pathway with our local care system. So sorry, this is a very busy slide, but I'm happy to share these slides with you, really just to ensure a standard assessment is done by the GPs that we work with, that they can refer into a community team which is able to deepen the assessment of the patient, and then who works with us, probably through a virtual MDT platform like this in the main, where we can sort of define what diagnostics we think are useful and what sort of management plan is needed. There are some patients with very severe symptoms who we would see directly in the tertiary clinic, and we're trying to work with the other hospitals in North Central London to support them to start working with their local boroughs, because there's definitely too many patients for us to manage them all within our one clinic. So we're trying to broaden our reach and standardise approach across North Central London. And I don't think you need to see that. We're finding it very helpful to use standard questionnaires to try and define symptoms in patients. And we're lucky we have an excellent electronic health record system at UCLH. So we're able to send these questionnaires out to patients to track on their progress and get a sense of whether our interventions are working or not. But there's a massive need for more research into this space, both into mechanisms and into the treatment options, and which diagnostics which we should be doing and what care pathways are effective. So Ondine and I are hoping to influence those high up in government to try and keep our research as patient-centered as possible. And we also need to, as you were saying, do as much learning as a sort of integrated network as possible, learning within the UK, and then I'm sure we have a huge amount to learn from other countries as well. So, sorry for the technical glitches, but I've left 2 minutes to spare in case anyone has some urgent questions.
Thank you, Dr. Heightman. As noted, we'll get the presentations and send to our delegates that have attended. We have 2 minutes to end our morning session, so that we can just go back and check our emails and finish some few things that we need to finish. Is there any pressing question that we have not responded to? Let me just say thank you to John. John, you almost answered. In fact, you answered the question that was raised around pre-employment medic. So thank you for that, John. I'll give Dr. Sipho and Dr. Deepak your closing remarks, and Melissa, your closing remarks. I see Prof has left because he has another appointment. Your closing remarks, Dr. Sipho, you'll be the first one to go, and then Dr. Deepak, and then Melissa, you will finish.
Thank you so much, Ntantla. I would just like to thank everybody for honoring meeting and time to this very important topic. And as previously said, I would like to think this is a beginning of a journey where we will collaborate, we will learn and advocate for our patients. Thank you so much for having given me the opportunity to present and learn from all of you.
Thank you, Dr. Deepak. Unmute yourself.
Yeah, likewise, the same. Thank you for this opportunity to talk to all of you about our service and some of my thoughts around getting a patient-centered service in place. I think, as Dr. Heightman has pointed out, this is still a lot of learning, and any data, anything that comes, it has to be a living service. It has to evolve and be there for the patient. And thank you for having me.
Thank you. Your closing remarks.
Yes, so yeah, thank you very much. It's lovely to meet you all, albeit briefly. And yes, it's almost too slow to wait for published research in this area. I think we need to be sharing our learning at pace. We've got a huge patient need, and I'm sort of concerned about how slow things are moving. We're now nearly a year following the first wave. And I'd like to see us progress to proper treatment trials in this space. So it'd be lovely to collaborate with you again in the future.
Thank you so much. Thank you, colleagues. This marks the end of our morning session. Let's meet at 2 o'clock South Africa time and 12 noon UK time. So what we'll do is that we'll have the presentations sent to everyone by tomorrow. And then the link to the recordings will also be sent to everyone, hopefully by Monday, because we are taking 2 days off work, Wednesday and Thursday. So bear with us, but on Monday we'll have the recordings done. If there's any other questions, we will take them in the afternoon. In the afternoon, we've got Dr. John Briefer, also from the UK, and Dr. Neil Fantonda from South Africa. They will share with us some aspects of the road to recovery. And also the last part of the day, we'll look at how medical risk assessments will be done in light of long COVID. Will there be any changes? What do we need to change as organizations, especially when we have to deal with the medical risk assessments? So thank you so much for this time. Kindly note that we are going to use the same link to join the afternoon session, and all presentations will be sent to you by tomorrow. Thank you so much. Let's meet at 2 p.m. South Africa time. Thank you.